should be pretty short today. We're just going to kind of wrap up and talk about, kind of go over just a review of everything that we've talked about the past several months. And of course, when we get there, we'll be talking about things in real time and in person. So it will be great to see everybody and be able to talk about some of these things, and then go back and I'll bring the copies of the PowerPoints that I did and that Aaron did for you guys, in case anybody needs them while we're there or wants them. And we can talk about all of this in action, in actual real time. So make sure that we're recording and get started. So we're wrapping up today. We're going to talk about everything that we've learned. So overview of all of our goals and the structure of Gift of Life and the cardiac training that we've done, especially in the ICU, as we've talked about, and all of you who have worked in there know teamwork and communication is so important. Us being able to feel comfortable with our teammates in order to talk with them about what we have concerns about, because sometimes as bedside nurses, we're the ones that are in deep, and we're there, for 10 to 12-hour shifts and looking over everything. And if we recognize something that we think is off, we have to feel comfortable to be able to talk to the physicians and the surgeons about that. Especially in the ICU when there's so much going on, people can kind of get focused on details and miss big picture. And so that's one of the benefits that we have as the nurses in there taking care of these kiddos. We talked about physical exam of the critically ill child. We talked about the arterial line monitoring, about medications that we're going to be using following congenital heart disease surgery. We talked about circulation, all the way back to fetal circulation, which is so important for the babies that are born with holes in their heart. We talked about the PFO, which is that hole that doesn't close after they're born that's supposed to close. Cardiac physiology, ASDs, VSDs, PFOs, tetralogy of Fallot, we talked about in detail, and we'll look at all of that again just a little bit today. We will be taking care of chest tubes, pacing wires, doing dressing changes, making sure that these kiddos are eating after surgery, which a lot of times after congenital heart surgery, these babies that are small don't want to eat, even if they've been eating well beforehand. The research has shown that it has a lot to do with bypass and the amount of time that they're on cardiac bypass. And so we'll be talking about working with that. And then, like I said, just really focusing and remembering how communication is so important for what we're going to be doing. Children are not just small adults, and those of you who haven't had the opportunity to take care of kiddos as much will get that opportunity when we're there in 3 weeks. The vital sign parameters are so different. Heart rate in an adult of 170 would make everybody extremely anxious and probably freak some people out, but a heart rate of 170 in a 2-month-old baby who's hurting and crying can be normal. And so this is all something that we'll think about. Parameters are different for saturations as well. So if you have a kiddo that's been in heart failure for several years because they have an ASD that hadn't been closed or a VSD that is just now going to be closed, we will accept lower oxygen saturations, right? Because we don't want to have a bunch of oxygen going and flood the lungs with oxygen, because that is not the circulation that that baby has been used to. Medication dosing is very different, and most all of our medications that we will be giving are going to be based on weight. But also we have to think about that some children who are overweight, we don't want to overdo either. And so there are always discussions with children. It's not just one ampule of something or a vial of something that we give to children like they do to adults sometimes. And so this is going to be important to be really careful and check one another on our doses, especially with narcotics. Pain management is extremely important post-operatively. So we talked about all of those unique things that we can do. It's not always just narcotics that will help with pain management. Many times with infants, even after surgery, they want to be held and fed. And so that's going to be important for us to facilitate that. These invasive procedures that we talked about, the arterial line, the central line, and the surgery itself are extremely invasive. And that is something that takes all the control away from a toddler or from an older child or a teenager. And so this is so important to be thinking about how this is such a big event in their life, even if it's just another day in the hospital for us. Monitoring their volume status, making sure their intake and output is at a decent level, and that they aren't voiding too much or too little, and letting the team know if we're concerned about that as well is extremely important. This is why we're going to be so cautious about watching our chest tube output, because if we have a kiddo that has had not much output for a few hours after surgery, we're concerned there, right? They should have quite a bit of output after surgery immediately. And so if they're not doing that, then we need to be concerned and figure out if the chest tube is patent. If they are pouring out blood, that is also something that is extremely important to let the team know as well. So it's something that we're going to be watching every hour and being very close with monitoring volume status, especially on the little babies. And then parents. Parents are a part of taking care of pediatric patients. All you guys know that. We used to joke years ago that the best patient in the ICU was an orphan who was completely sedated. And some of that is a little bit true sometimes. Sometimes having the whole family to take care of is a little bit more complicated for those of us that are bedside nurses. And so we have to be very mindful that some parents are very fearful of being in the ICU. This is not something that is normal to them. It's not something they've ever experienced before for many of these babies and children. And so we need to really take them into account. And they are the ones that know their kids best, right? So if the baby is not wanting to eat the food that we're trying to provide from the hospital, the parent is going to be the one that knows what that answer will be most likely. And so we need to involve them in cares when we can. Let them understand that yes, there is an incision there and sometimes a chest tube even, but that they're able to help us change diapers if they want to. If they don't want to, that's fine too. But we have to be very mindful of the parents and family also. Many times they'll be sitting on that bench outside the door, but just to let them know that they are welcome is important. So quick review of the post-operative ASD, VSDs. I didn't go back into the anatomy with this because we can certainly do that when we're there. For the ASDs and the VSD repairs, they're going to have an incision down the middle of their chest, and that's going to hurt, right? Not the incision only, but the bone has to be cut in order for Dr. Soto and the other surgeons to get to the heart. And so that's going to be tender and sore, and we're going to have to work with them regarding getting up and walking and moving, even though they're not going to want to at first. Those should generally be closed with patches when we're there. And so you have to be mindful of those pictures and the videos that we showed about all of those sutures around the patch. And things that can happen because of the patch, right? The body recognizes that as something that hasn't been there before. So it's pretty much a foreign object that is placed appropriately, but it's a foreign object in the body. And so now the body is trying to figure out what to do with that. There's going to be inflammation surrounding the surgery site. There's going to be inflammation around those sutures. And we talked about arrhythmias being one of the big problems, that even heart block that can happen after surgery. And many times it's because there's been something put in place that the body is trying to then reject or get rid of. And so the kiddos will end up having arrhythmias often. Having effusions or buildup of fluid around the heart or the lungs can also be a problem. This is why we have the chest tube. But like I said, if we're stripping the chest tube and doing all of our maintenance of what we should be doing and it's not draining, that's when we need to be mindful that we need to be figuring out if there's a problem. This is why we get x-rays every day. Sometimes it seems cumbersome to have to, you just got the baby to sleep finally from hurting, and now all of a sudden here comes the x-ray machine, and we wonder, why do we need to be doing this right now? But it's oftentimes to see those effusions and see what's going on with their fluid status. The same thing for the echocardiograms that we get while they're in the ICU. They'll be doing those quite a bit as well. Many times they have an echo before they come back from the operating room, and then they'll get an echocardiogram sometimes that night or the next morning. And so those are all the reasons that we do that. Those patches are sewn into place. Think about how tiny that section is. Sometimes those patches have leaks. Maybe there's a leak around one of the sutures. Maybe the force is so strong that it's not doing exactly what we need it to. And there can be leaks around the patch too, which can cause a murmur again and have some problems. And these are all just things that we are helping monitor for post-operatively. With our wonderful dressing changes, there will not be wound infections, but that's always a risk too. And so we'll be watching for all of these things. The incision care is something that we'll need to be very mindful to be teaching the parents as well, because they have to go home with these wounds, right? We're not keeping them in the hospital until the incisions are healed, nor the wound from the chest tube. And so we'll need to teach them how to take care of that at home as well, which we'll be doing in time. Sorry, y'all, the dog is pushing on my computer, so she's trying to help me. That's why it's going all sideways. PDAs are a little bit different because the surgeon, Dr. Soto, will come from the side. So that's a thoracotomy approach. The older children that have surgery from a thoracotomy approach are often much more sore on that side. The left side generally, obviously, is where they're sore, and that is cumbersome for them. And so sometimes they'll need more medication. So that's just important to keep in mind because they hurt more. Also, because of the direction of the surgery, you can actually have nerve paralysis where they'll have a lot of babies and kids will have sore throat after they've been intubated for surgery, but these can actually affect the laryngeal nerve, and that can cause problems too. So let's be something that we'll monitor for after surgery to make sure they're swallowing well and talking well or making noises appropriately. PDAs, obviously they can have postoperative infection too. We haven't seen any of those and hope to continue that trend. When you go through the side for a thoracotomy, remember we talked about also that that's where those ducts are. And when you accidentally ligate one of the thoracic ducts, they can have chylothorax, which is when you have that milky white substance that we would notice in the chest tube. That is not a good thing once the ducts are ligated. It will heal in time, but initially the kiddos can't have any diet that has fat in it. And so that makes it very hard for an infant who's on formula, because you guys know that all formulas have fat because infants need that. But when we have chylothorax, you can't give them fat. And so there has to be many discussions about what the kiddo can or will eat. We've turned to coconut water the couple of times that I've seen it happen in Guyana, and that has worked. Again, not as great nutrition, obviously, for a growing baby as we need, but for if you can do that for 2 or 3 days while the duct heals, generally they will get better from that. Long term, you can actually have scoliosis develop. Sorry, y'all, dogs. You can have scoliosis develop as well. Hey, stop. From a PDA, which is so interesting. Just thought that was interesting. And then they can have also some more opening that happens, or it doesn't completely heal like we talked about. And if they have that, they can have more opening and mixing of their blood. Coarctation of the aorta, moving on. These kiddos is a great picture. This is quite tight, and obviously not all of the kiddos will have quite this tight of a coarct of their aorta, but think about opening that and what it takes. Many times Dr. Soto would choose to do what's called an end-to-end anastomosis, where they cut the part around this tightness here, and then they sew the two ends of the aorta together. You know the very high pressure system that an aorta has. And so because of this, when you put stitches in there, we have to be very, very careful about their blood pressure after surgery. We do not want their blood pressure to be really high. Sometimes easier said than done. Perhaps we have a baby that has Down syndrome, who is fussy, who is hungry, who is hurting, and that's not always so easy to get their blood pressure down, but that's going to be our job to help get that down. You can also have chylothorax from the thoracic duct ligation if it occurs during that surgery too. Of course, they will need pain control, and even these more difficult and longer bypass time surgeries, we're going to try to be getting these kiddos up and moving once they're extubated, and we can do that. So usually within the 24 hours, as long as they're doing well from a breathing standpoint off the ventilator, then we will try to have them up and moving around. We're going to be taking out chest tubes, right? We generally, Dr. Soto will take them out at the bedside, and then we'll be taking care of that. We're going to be the ones that are giving the pain medicine before. The team is generally really good about saying, okay, he's going to be here in 30 minutes, or he'll stop by in between surgeries to get that out. And so we'll give the kiddo a pre-medication, usually a narcotic for that, because it is painful. Especially the idea of being scared as well amplifies that for children. We will be the ones getting the dressing off if Dr. Soto wants us to, and assisting him with that. Then he or another one of the surgeons will take the sutures out and pull the chest tube out. We'll make sure to have the occlusive dressing ready to put over the insertion site, because that is a communication right to the inside of the body. We don't sew it when he takes the tube out, but that will close on its own pretty quickly. But we need to make sure to have that pressure dressing ready, and we'll work on all that together. As you can guess, many cardiac surgeons are very specific about their dressings, and so we will help guide that process, and of course have all the supplies ready for everybody. For arterial lines, the nurses are actually the ones that will be doing this. So we will be doing this, removing the tape, and the dressing is sometimes more cumbersome and more dramatic for the child than taking the arterial line out itself. If it's sutured, which it will depend on who our anesthesiologist is, whether or not it's sutured, then we'll have to cut the stitches, which are just holding the line into the skin. And then we'll remove the arterial catheter, which is, like I said, once you've gotten that far, it's just the same as an IV catheter. But man, that dressing and tape and getting that off is often a lot more of a process, especially for a toddler. It's hard for them to understand what's going on. And here we come again at them, ripping tape off, and they don't like that. Because it's an artery, we have to hold pressure. So that's also another thing that we have to navigate, especially with toddlers and younger children. After we're done, they want us to let go of them, but we have to hold pressure until that artery gets clotted at the surface, or it'll keep on bleeding and keep on bleeding. And so we'll put pressure dressings on those as well in the ICU. Central lines, we'll work with the intensivists, and we could be also the ones taking out central lines. We looked at videos of all of this, and so I won't read it all, but it's basically the same thing as the arterial line, aside the fact that it doesn't tend to bleed as much. And obviously you can't put pressure on it great, depending on where it is, especially if it's up in the neck or the chest. Can't put pressure up there, right? So it's just something that we'll be watching and be mindful about. Foleys, of course, that's us. We're going to be the ones taking those out. The discussion about when to take those out post-operatively is always an issue, because, as we said, intake and output is so important in these children. For this, the tape, again, especially on an older kiddo that has a little bit of hair on their legs, that can be very hard to navigate that. The biggest part is, and this is with putting a Foley in or pulling a Foley out, is making sure that balloon is totally empty before you take it out, and making sure it's completely into the bladder before you fill it up when you're inserting it. And we'll get those out, and then make sure that they can pee on their own within 6 to 8 hours after we've taken it out. Moving on to report. So when we're handing off to one another as bedside nurses between day shift and night shift, or whether we're giving report in the morning to the surgeons and the whole team, which that team can get really big sometimes in the ICU, and I understand that that can be nerve-wracking. But the best thing that I can tell you guys is a complete and organized report that is systematic is going to be the best way to go. We're handing off to one another at night, and I know we're tired and we've had long days, or it's been a night where we've had a kiddo that's bleeding a lot and we've spent all night at that one kiddo's bedside. We still have to make sure to use that same systematic report to one another, so that we feel comfortable that we're handing off the child with the best report to be able to take care of the child the best way. No matter what, I have found over the years that even 27 years later, I'm still using systems report because that is what works best for me. And so, and again, you can kind of adapt that to what you want to do, and we will bring templates with us, but giving a systems report for me helps best. This is an example of what I'm talking about there. Airway breathing is what I start off with. So perhaps I'm signing out to the night shift and we have a kiddo that had a VSD repair today. I would let you know airway breathing. He is on 2 liters of a nasal cannula. His average respiratory rate has been about 20 to 30, depending on how much he's hurting. His breath sounds are clear. He's breathing easily and unlabored. We haven't had to give him any breathing treatments since he returned from the OR. He was extubated when he got back to the ICU. And the parameters for weaning his oxygen tonight are as long as his saturations are greater than 90%. You can wean his oxygen to room air. He has a chest x-ray ordered for the morning. Then cardiac, I would give you, if today was his first day after surgery, I would give you his bypass time. So his bypass time his cross clamp and bypass time was approximately 25 minutes. No residual murmur is heard. He had an echocardiogram when he got back to the ICU, and that shows good function with no residual VSD. His blood pressure has been in the 80s to 90s systolic. His pulses are easily palpable bilaterally. His capillary refill has been brisk. He is warm, well perfused, and doing well from a cardiac standpoint. He is currently on no cardiac medications. However, they are talking about maybe giving him Lasix tonight, depending on what his fluid status is. For neurologic, which I know is not alphabetical, but we used to call it the brain so that it would help everybody remember. But for neurologic, I would tell you that he's been awake and alert since his surgery. He's a little bit fearful of staff coming to his bedside, but is doing well when his parents are there. We have given him fentanyl one time right after surgery, and since then have been able to just give him Tylenol and Motrin, and he seems quite comfortable with that. He is alert, moving all of his extremities, and seems appropriate neurologically. Fluids and electrolytes, since he got back from the operating room, he had been on IV fluids at maintenance for 3 or 4 hours, and then he started drinking. So we have since stopped his fluids. His last sodium level was 136, potassium was 3.4, ionized calcium 1.1, and we have not had to give any electrolyte supplements since he got back. That's completely fine. You can also give in the morning, especially, you could also give his intake and output for the day, because that would be very helpful for the nurse that's giving report to the surgeons the next morning. So overnight, the nurse may sign out to me in the morning and say, for the past 24 hours, his total intake was 850 mils. His total output was 1,000 mils, and we wanted a negative fluid balance. So that has been good. Total chest tube output, 120 mils, and then you could tell me as well how much he took by mouth. That would just help for us to have that fluid and electrolytes solid, so that when we gave report to the oncoming team, that would be good. GI, he's eating well. He went ahead and ordered a dinner. So far, he's taken his juice well, no problems, no emesis. He is on Zantac post-operatively, and you could talk to the team about maybe stopping it once he's eating well. He has not had a bowel movement since surgery. Hematology, I spelled that wrong, so I need to fix that. Hematology, you would give the last H&H that you had, and coming back from the OR, he should absolutely have that. So we would report off his H&H 8.9 and 36. They did not have to give blood in the operating room, and he has not been bleeding much from his chest tube. Infectious disease should not be an issue, obviously, but you talked briefly about what his Tmax has been since he returned from surgery. His Tmax is 37.8. He is on ANSEF for 3 doses post-operatively. So I would let you know that. Joints and skin, if he had anything that you needed to talk about at that point, that would be the time. His dressing is intact. Since he got back from the OR, we have not been able to see his incision because of the dressing. However, it is clean and dry. His dressing on his arterial line has a little bit of blood that has been present since he returned from the OR, and we have not changed that because it would likely come out tomorrow. Kidneys, he has a Foley catheter in place right now. So far, his urine output has been 1.5 mils per kilo per hour since he returned, and he has not yet received any diuretics. They are talking about giving him diuretics tonight. Lines, he's got 2 PIVs in his arterial line as well as his Foley. Likely the Foley catheter and the arterial line will come out in the morning. Medications that we haven't talked about would go here. So if he were on an additional medicine that I hadn't mentioned in neurologic or in the fluid and electrolyte section, or the GI section, then I could say that here. You don't have to repeat or list out every single medicine the patient is on. If he was on infusions of something, this would be a good time to also just kind of reiterate that his milrinone is at 0.5 micrograms per kilogram per minute, or his dopamine is at 5 micrograms per kilogram per minute, and just kind of make sure that you guys check that together before the day shift nurse leaves or the night shift nurse leaves, depending on which one it is. He has no known drug allergies, and then his parents have been here. They're quite fearful of coming in, but they came in and visited a little while earlier. They were updated on the surgery, and they were able to speak with the intensive care doctor. Plan for tonight, we need to just keep him comfortable and let him eat his dinner. IV fluids have been stopped, so in the morning, if everything goes well, he will have a chest x-ray, and then plan on removing his arterial line and his Foley catheter. So just a brief plan that kind of summarizes everything that you've talked about, what the plans will be. And then, you know, again, passing off from night to day, you would let them know that that was the plan for the following morning. The goal with these systems reports, obviously, is that everybody's saying the same thing, right? As you guys know, especially on complicated patients, sometimes it becomes like a game of telephone where I give report about his parents who are so dramatic, and this parent did this and this and this, and then I come back 3 days later and it's a whole different story. And unfortunately, I think with human communication that does happen, but for sure in the ICU on these kiddos, we just need to try to be as thorough as possible and then as systematic as possible, so that we're making sure to pass this on to the next shift if it's not the same nurses taking care of them. Communication, we talked about heavily over the past several months. I think the biggest thing is that we are very big on mutual respect with ICHF. It's very important to us that we respect one another. I want you to be able to come to me with anything that you have, you know, if it's something that's bugging you about a patient, if it's something that's like this question and you think, oh my gosh, it's so dumb. No, there's no such thing. And I respect each and every one of you. I am going to learn almost as much from you, if not more, than I'm teaching you guys when we're down there. And so that's very big. I completely respect and appreciate the doctors that we work with. Absolutely. They've been through a lot of training and they're very specialized in their training, but also need to be able to trust them and have communication patterns with them, right? And so they're very, all of them are very open to having friendly discussions that are professional, and sharing that knowledge amongst each other. And then just being clear with our messages. I have a couple of videos. You guys know I love videos, but I have a couple that talk about, you know, that telephone game like I was talking about, where I'm trying to call the surgeon in the middle of the night and I'm like, yes, Dr. Soto. So this kid had surgery today and it was a VSD repair. He did the surgery, so he knows, right? And it's 2:00 in the morning. And so I just need to be clear, you know, with my message. And so I think that's so important. If also, if you're worried about something, if you have a kiddo who you really tried to keep comfortable not giving narcotics to, and there's just something's off and something's not right, you kind of don't need to go on for 5 minutes explaining all that. And those of you guys that know, and obviously you all know me from the past several months, I tend to kind of over talk sometimes, but having clear direct messages is going to be so good and necessary as well with these kiddos that are critically ill after their surgeries. Let's look real quick at tetralogy of Fallot. This is going to be one of the most complicated surgeries that we do if we end up doing this repair while we're there. I did go ahead and put a picture in here for us to remember that it is many components, right? 5 that make up the tetralogy of Fallot. And so this is important to just kind of think about in the back of your mind what they are doing and all the things that they're operating on. Following surgery, things that can happen are those valves can start leaking and have regurgitation. And so this is why those echocardiograms are so important. And the VSD can keep leaking even after the repair. Sometimes in the future, VSDs need to be re-repaired after this repaired surgery. And so these are things obviously that we're not looking at straight away in the ICU, but we're watching the kiddo's blood pressure. We're watching those saturations, right? We don't want their saturations to be in the low 80s after they've been repaired, but sometimes for a little while they are. And so this is all the things that we're watching for. Over time, the right ventricle can start getting really big because it's having to work harder now to pump the blood to the lungs. The left ventricle can get to where it doesn't want to work properly because it hasn't really worked properly in the beginning. They can have a lot of arrhythmias after surgery, so we're absolutely watching for those things. And unfortunately, there can be death even after surgery, after a surgical repair. We should not be seeing any of that, obviously, but this is why these kids are followed very closely by the amazing cardiology team there in Guyana as well. It's a forever relationship, right, with them once they've had a big surgery like this one. Pain management, we talked about a lot, a whole lecture on that, if you will. I don't know if lecture is the right word, but we talked about that. We want to be using Tylenol, NSAIDs, and these sort of things if we can. Of course, these babies, some and older children are going to need narcotics, but we absolutely don't want to be giving narcotics every single time we can. Yes, it often makes them go to sleep. However, we need to make sure that they're eating. We need to make sure that they're walking and doing those things that they're not going to really feel like doing if they're getting fentanyl every hour. And we will talk about too, and we did talk about a little bit in the lecture, that narcotics also have bad effects as well, right? They make kiddos very constipated, especially in conjunction with anesthesia. And so that can be a huge problem if they're getting a lot of postoperative narcotics and they get constipated. They can get ileus and they will be miserable, more miserable than they were with their chest tube hurting. So we need to be very mindful of that. Also, morphine works well and acts longer than fentanyl does. However, it makes so many kids very nauseated, and it also makes a lot of kids itchy. So we do not want to be just giving that every time we can either. Fentanyl and morphine also have respiratory depression. They can affect the blood pressure. So we need to be very careful when we're doing all of those things. Our narcotic doses, we will check each other with every time that I'm going to be giving fentanyl or morphine. I will ask one of you to please double check and make sure that I have the right amount in my syringe. That is not anything that we ever want to give too much of. Also too little, because then what's the point, right? So we need to be going over the dosing correctly and make sure to double check one another on that, because it can be this little tiny dose for a baby and it's not super easy to draw up, and we just need to everybody be mindful of that. Moving again is a lot of my kids that I work with now that have brain surgery many times have an incision on the back of their neck. So they don't want to move their neck. And I will walk in the next morning to see them and they'll be like, stuck in this position. And I'm like, will you move your neck? And they're like, nope. And so I have to talk to them. I promise if you start moving your neck a little bit at a time, it's going to get better and better. Well, none of them believe me, right? But it is the truth. And like I said before to a lot of you guys, the kids in Guyana are always wanting to get out of the ICU because it's so cold in there. So many of them will get up and move for us the next day with not much trouble and not much crying, because they want to get out of the ICU to go for a walk. But getting these kids up and moving, even taking little walks with the chest tube, is fine. Sometimes it'll take 3 of us grown-ups to take one 4-year-old with a catheter and a chest tube for a walk, but we will do it because it's important to keep the lungs clean. It's important to help the healing process. So that is part of our pain management too, is getting them up and moving them. And then remember, the baby's crying sometimes just because they need to be fed, right? feed the baby. We used to have an intensive care doctor that was from Colombia that I worked with for several years. And he would always walk by when he would see the nurses looking for narcotics, like feed the baby, love the baby. And this is why we got in, a lot of us got into pediatrics anyway. And so sometimes that's all they need is to be fed, just like this little baby here. They might not even need a narcotic or a pain medicine right now. They just need to be fed. We've talked about intake and output, so I won't keep harping on that for you guys, but do remember that it's an every hour thing. This is not something that we do every 4 hours or every 6 hours, not in the cardiac ICU. Every single hour, we need to be thinking about what they're taking in and how much they're putting out. Many times we want a negative fluid balance, and we will talk about that with the physicians that are on in the ICU that day, because a lot of times we want them to be what we call a little bit dry in order to help make sure that cardiac function after surgery is good. Sometimes their blood pressure is low and they're not peeing, and we might have to give them some fluid back. And sometimes that's in the way of saline. Sometimes it's in the way of blood, depending on what they need. And so these are all the discussions that we're having, but we all need to be knowing how their fluid balance is and what their status is before we can make those decisions. So again, if we're concerned, we need to let people know. Remember, we talk about that over and over. We might, and we probably will, have some kiddos that we have to use those pacing wires on. That's not always the best, most fun part of our job, for sure, especially when you have to get that kiddo hooked up and start pacing right away. In the case of heart block, this is something that absolutely has to happen pretty quickly, so we'll work on that together. But postoperative arrhythmias, including junctional ectopic tachycardia, which Erin spoke with you about, are really big deals, because even though they have a heart rate of 180, that heart rate is not perfusing. And so that's almost as bad as having a kiddo with heart block. They will, almost all of them have pacing wires for us to be able to hook up to. And this can help once you get them paced. Oftentimes their blood pressure gets better and they feel better. So this is something that's really, really important. And again, we talked about the reason why when we're repairing these holes around the SA node, which is the node that talks to the rest of the heart to tells it how fast to beat, then there's swelling right after surgery that many times can cause them to have heart block or arrhythmias. And so we have to pace them until that swelling goes back down or until things accommodate. This specific article talked about how conduction usually is completely normal within 10 days. Many times it'll be much sooner than that. We will see them get back to normal in 3 or 4 days in the ICU. And then I put a little chart down here at the bottom that just talks about our pacing, and we'll look at that, of course, more closely when we're actually doing it in real time. But the ways that we can pace, we'll have the little pacemakers with us. Another thing I think that Erin mentioned too, we have to remember to check those batteries. That's important as well. I think I told you guys I've learned several lessons the hard way. And one of the lessons that I learned years and years ago was to make sure that you have new batteries ready for that pacemaker. Because if you're using it 12 to 24 hours a day, you can see those batteries can get low. And so having them close and handy is extremely important unless you want to get in some kind of trouble. All right, guys, just kind of wrapping up again. We're just always thinking about the status of the kiddo, that you walk into the ICU, and one of the pictures that I showed you guys on our first lecture had all of those machines and all of those pumps and the ventilator and all the lines and everything that are attached. And all of that is important because, yes, ultimately we at the bedside are the ones that are responsible for that. But look at the baby, look at the child. Walk in the door and do that 5-second glance. How does the child look? Are they breathing easily? Are they comfortable? Are they pink? Are they blue? All of those things we need to remember. Don't just immediately start checking the pumps, making sure the drips are right, looking at your oxygen to make sure it's connected. We want to be looking at the child because that gives us a good general picture of how they're doing. Communication is so important with one another and with the physicians, and we will harp on that when we're there. Again, we are a team with all of the same goals. For us, I just wanted to give you just a little bit briefly about us. Everybody that travels to Guyana will be volunteers. We are all volunteering our time. We don't get paid for coming. I just wanted to make sure that everybody knows that. Many of us are using our vacation time at our jobs in order to come, and that's because we want to. This for me it was life-changing the first time that I had my trip down there to see you all and take care of the babies in Georgetown. And I cannot believe that it's been 5 years since I've been able to come, and I cannot wait to see everybody again. We want to again learn from you, and I have learned many, many things on my trips to Guyana, and I'm very, very thankful for that. But also to continue to help you all establish the ICU to be open and running and doing very well, as Dr. Davidson has in mind for the next several years to come. All right, anybody have any questions? I want you to holler at me. Please remember to email in the meantime. We'll be seeing each other in 3 weeks, but if you're thinking about something or have a question, you guys can always do that. And we will see you guys soon. Thank y'all so much for those of you that could join today. Let me stop recording. Does anybody have anything?